Good evening, everyone, and welcome to the AstraZeneca Symposium. I will introduce the speakers shortly. I just want to say that this is a very important moment in our society's history. It is a chance, it is a time where the horizon is changing, where integration is happening between surgeons, oncologists, as well as pharmaceutical companies. Today, the AstraZeneca Symposium is going to be entitled Adjuvant Targeted Treatments After Lung Cancer Surgery. It's a non-promotional symposium organized and funded by AstraZeneca. Next slide, please. My name is Eric Lim. I am a thoracic surgeon from the Royal Brompton and Harefield NHS Foundation Trust. Next slide, please. And here are some of my disclosures. Next slide, thanks. The AstraZeneca SCTS Symposium is organized as part of the Society for Cardiothoracic Surgery annual event. AstraZeneca is delivering a virtual education symposium to share best practice and innovative thinking in the management of lung cancer patients. Today's session has a particular focus on adjuvant targeted treatments following surgical resection in early stage lung cancer. Next slide, please. For the symposium today, I am delighted to introduce my two colleagues. One is Dr. Tom Newsom-Davis, and the other is Dr. Riaz Shah. Both of them are well-known oncologists in the UK. So Tom is a medical oncologist. He works at the Chelsea and Westminster Hospital. And Riaz is also a medical oncologist working at Maidstone and Tunbridge Wells in Kent. Next slide, please. And today's symposium, we're going to talk about a few key issues. The first is going to be a talk on the evolving evidence for adjuvant targeted treatments after surgical resection, and that's going to be given by Tom. I understand Tom is having some technical difficulties at the moment and will be connecting or reconnecting in a few minutes. Once Tom has delivered his talk, then there will be an opportunity for you to ask all the questions that you've ever wanted to know about adjuvant targeted treatments after surgical resection. As mentioned, these are changing times, and now the future direction of where we're going is going to be highly integrated. After that, we are going to have a live debate, which is myself against Riaz on whether surgeons should be prescribers of oral adjuvant treatments. It's going to be a very short presentation. I told Riaz no more than 5 slides, and I think we will both clearly fit that remit. After that, once we've done our debate, it will be a chance for you to participate and let us know your views on the live Q&A and panel discussions. Once we finish that, we'll have a combined case study where myself and Tom will be presenting to you about how surgeons and oncologists work together for the benefit of the patient. And after that, another opportunity for a Q&A and panel discussion. Then we will summarize and close the session. Whilst we are waiting for Tom, we might ask you to post any questions that you have live on the Q&A sections of the application. And without further ado, we are going to move to the next slide, please, and allow Tom just a few minutes to connect. So we'll be grateful if you bear with us and let us know in the comments box if you have any questions or suggestions, or if there is anything in particular you want to focus on. If Tom is any more delayed than it is, we might change the order slightly and start the debate. So we will give Tom maybe 1 or 2 minutes to connect up. Okay, since Tom is still struggling, Riaz, should we just dive into the debate? and maybe we can get the session going. So for the presenters, let's move on to slide 23. Thank you very much. So once again, this is me, Eric Lim, and I'm going to start this live debate with my worthy opponent, Dr. Riaz Shah. Next slide, please. Here are some of my disclosures, and we are debating the motion: surgeons should be the prescribers of oral adjuvant treatments. Next slide, please. So for me, I would say that times are changing. In the past, we used to have a situation where surgeons would undertake an operation, and then in certain patients, we would refer them to oncologists for them to consider whether or not adjuvant treatment should be prescribed. Adjuvant treatment in that time is generalized chemotherapy. Most patients wouldn't even come back or make the appointment or even consider wanting to have any adjuvant chemotherapy, because quite frankly, it's quite ineffective and doesn't achieve very much. Most of the systematic reviews and meta-analysis suggest that the survival improves by a small 20%, and we are not even sure if it influences recurrence rates. So in the past where there was a lack of effective adjuvant treatments, situation and times are now changing to highly effective adjuvant treatments. In the past, generalized chemotherapy was associated with poor survival, unknown effect on recurrence, and now, and you'll see when Tom presents, that the massive improved survivals and lower recurrence rate really changes the landscape. In the past, we had intravenous chemotherapies. Today, we have oral, molecular, targeted treatments. And in the past, the adjuvant generalized chemotherapy was associated with a high incidence of adverse events, and today, it has a very acceptable tolerance profile. Next slide, please. Whatever we do, we always place the patient at the center of our focus. Now, I think as a thoracic surgical community, we need to move towards the concept of a surgical oncologist. And this would involve more effective screening. If it's in our interest to identify patients for molecular targeted adjuvant treatments, then we would be identifying patients upfront, even at the time of referral. Surgeons are in the best place to provide more detailed discussions with a higher acceptance for patients when discussed upfront, understanding that this is part of the proposed pathway. Surgeons will be much more invested in screening, molecular screening, so that we can better identify patients who are suitable. And rather than having the patient move from surgeon to oncologist to surgeon and back and forth, we are able to then move to single site management. Next slide, please. And as surgeons, we would deliver a joined up approach and follow up after surgical care. As we manage the post-operative complications, we would also manage the adjuvant treatments. At the same time, screen for recurrence. I can't think of any more holistic and expedient and efficient management to deliver improved length and quality of our life for our patients. Thank you. Next slide, and over to Riaz.
Can you hear me? I believe I'm live. Well, thank you very much for the opportunity to speak. Next slide, please. These are my disclosures, and the next slide, please. You'll be glad to know that this is my only slide. What I would like to say is, thoracic surgery has become incredibly fascinating. There's so much going on. When I first became a consultant, oncologists didn't want to treat lung cancer. It was a prior subject, and cardiothoracic surgeons generally frowned on a career in thoracic medicine. And today we're in a scenario where the opposite is true. Many a cardiothoracic trainee will choose to become a thoracic surgeon because it's amazing what's going on. There's so much to develop, so much to get involved with aside from systemic treatment. We've established video-assisted thoracoscopy in the management of this disease. We've got robotic-assisted surgery coming in. We've just had a big randomized trial showing a potential survival benefit for over lobectomy in early stage lung cancer, presented a few weeks ago at a big international meeting. I mean, an absolutely astonishing time. We're, fingers crossed, not that far away from having lung cancer screening, and the amount of work and potential new technology for you guys to be resecting and curing patients of lung cancer is astonishing. So to my mind, what do we want our surgeons doing? Do we want them operating, or do we want them supervising patients on systemic chemo? And I would put to you the case for getting involved in that pathway is really very weak. I mean, there are thoracic surgeons all around the world that get involved in SACT, but usually it's driven by one of two things. Either it's out of necessity because, you know, if you're a thoracic surgeon in rural India, there may only be one medical oncologist 30 miles away, and there may be 1 million people between you and that person, and you simply have to get involved. So necessity can drive it. And sometimes, let's be honest, reimbursement drives it. You know, there are health economies in this country where doctors are paid directly by clinical activity, and so they don't want to relinquish activity. But here, we have the advantage of a multidisciplinary team approach. We all look after each other. We'll work together collaboratively. Now, the surgical unit that serves my practice is Guy's. One of the surgeons said to me they think they do 600 curative lung cancer resections a year, huge number. Now, 5% of that is 30 to 40 EGFRs a year. So now that adjuvant osimertinib has just got a license, putting 30 to 40 patients a year on adjuvant osimertinib, looking after them for 3 years on that treatment, within 3 years, you'll have 100 patients, 150 patients on this drug. You're going to need to employ a whole bunch of other surgeons whose only job it is to micromanage these patients. And it's not just about keeping people on a treatment. You know, there's 30-day mortality. There's all sorts of logistical rules and regulations around the delivery of systemic chemo. Now, one of the things that comes up is early adjuvant treatment is better. And there are lots of studies, small case series showing that the early initiation of adjuvant treatment has a survival benefit, but it's all non-randomized. Of course, early treatment has a survival benefit because the people you give treatment to early are the fittest people who bounce back the best from surgery. So they're always going to have better outcomes. You can't really say that without performing a randomized study. And here we are, we do NDTs, we have reflex EGFR testing, ctDNA technology is going to be coming in. You're going to know the EGFR result of any patient weeks before you even perform your surgery. So there's plenty of time for the oncologist to see the patient and get their heads around starting adjuvant treatment if so required. Many of the patients going on adjuvant TKIs may also need adjuvant chemo. So it's a very complex discussion. And then the other thing I want to reflect on, and we can use, you know, TKIs are potentially toxic drugs. Many of them cause cardiac issues. Many of them cause QTc prolongation. Many of them cause liver function abnormalities. And actually, the first 6 to 8 to 12 weeks when I initiate a patient on one of these TKIs is a very, very difficult 6 to 8 weeks, because that's when all the toxicity happens. That's when you need to watch your patient like a hawk. And many of you will see EGFR patients that, for example, I've been looking after for a year or 2 years. Well, those patients hardly need any micromanagement. They're very straightforward. But the first few weeks are very critical and very time consuming. So I put it to you that there just isn't a case for it in the UK. I just can't see it. I end my case.
Thank you. Thank you very much, Riaz. Very interesting approach. Can I say that surgeons are already following up our patients, so the additional follow-up of the patients we are already following up wouldn't really add too much of a burden with regards to the administration of oral TKI?
We're debating now. That's good. Well, you know, it's quite complicated because you need to have a setup to deliver the treatment, see the patient, assess the patient, do the bloods, prescribe the next cycle monthly in many cases, or 2 monthly, So I would say it's fairly onerous. I mean, having a patient on a TKI is a lot easier than chemotherapy, but having a patient on a TKI is not a fire and forget type scenario. It requires ongoing management. And I think in the modern era, we're looking at neoadjuvant data for IO. We could easily be giving some form of neoadjuvant strategy that involves immunotherapy a few years from now. I'm just hypothecating, I don't know, but there is emerging data coming out. Now, a lot of these TKIs interact adversely with IO. You know, the rates of pneumonitis can be substantially higher when you're giving these treatments to IO pre-treated patients. So I don't think it's that. I mean, it's doable. Look, anyone could be trained. You know, I have a whole team of fantastic nurses who micromanage many of my patients on this, and they're fantastic specialists. And I've no doubt that there is no thoracic surgeon in the country who couldn't be trained to look after someone on osimertinib. My issue would be, I'm not sure it's an effective use of their time.
Yeah, I wonder what the surgeons' opinions are with regards to this. So, you know, please feel free to enter your opinions in the live Q&A session, and also to complete the polls during this. We've got a question from Chiara Proli, who's asking, are there any specific training requirements which would enable surgeons to prescribe TKIs, if it ever comes to that, for example?
Well, all I can say is it took me 4 years of medical oncology training and a bit of acute medical take to get a certificate saying I could do it. So, I mean, I don't know. I don't think we've ever had a training program for giving systemic anti-cancer treatment not prescribed by someone who's a qualified oncologist, be it clinical or medical. So that is a discussion that would have to be had. And I don't even know who would be in charge of making those calls, but I suppose there would need to be some sort of, there would need to be systems in place to ensure those patients have out-of-hours access to care, to help, acute oncology. There's all sorts of little nuances to giving systemic treatment. But the main thing is, I don't think it's as time in consuming as people think. Actually, a lot of my EGFR patients are very complex, even though they're on osimertinib, even though they could be doing very well. There's all sorts of issues. There's some of the longest consultations I do, brain management, brain screening, CT imaging, interpreting the CT imaging. There's always slight changes here or there. Back to the MDM, is that biopsiable? Is it not? You know, it's a whole caboodle of stuff that comes off. It's not just here's some tablets, disappear, I'll see you in 6 months. It's very different from that.
But we are surely at some point that oncologists also themselves needed to be trained on how to prescribe it, because prior to 2009, Tony Mock's paper on gefitinib, nobody had prescribed a TKI in the world, and it was introduced from then. So at some point, oncologists themselves started out with the new drugs.
Oh yes, of course. I mean, you know, we all start somewhere. You know, it's 5 years ago that I prescribed the first dose of immunotherapy to a patient under my care, and I had zero experience before that. And now I treat hundreds, you know, probably 200 patients a year now. So yes, I mean, there's always that, but that's not the point. I think your clinics will fill up very quickly if you're talking about delivering that in an NHS service. And you're saying that you want a surgeon to look after a patient for 3 years of adjuvant osimertinib is a great example. That would be, I would say, 5 to 10 appointments a year, clinic appointments, prescribing on electronic prescription. I mean, I would suggest to you that if any of your surgeons came and had a look at what it takes to prescribe chemotherapy on some of the absolutely awful electronic prescribing systems we're forced to work with, I think they'd just walk away down tools. It is, onerous, time-consuming. and honestly soul destroying half the time. I don't know if Tom agrees, but it's not straightforward.
I got a comment from a surgical trainee, Alan Dawson. He says there are multiple therapies, including oral TKIs, immunotherapy, and some are IV. Limiting treatments to oral therapies, presumably by surgeons, would not serve patients in the best interest. So I'm not sure if Alan is proposing that we should be doing both oral and intravenous adjuvant treatments, or if this is the start of the can of worms being open as to where do we start, if at all, and where it all actually ends, and whether surgical oncology might be its own independent, specialty in the future.
Well, I think there's a huge space in the neoadjuvant setting for surgeons to get really involved in what treatments are given, the data, the clinical trials. It's a very, very exciting area in thoracic oncology, the neoadjuvant setting. I think once the definitive surgical procedure is done and, if you like, the dust is somewhat settled, then I think, you're talking about adjuvant treatments that are potentially protracted, going on for years, reasonable toxicity profiles. Osimertinib causes left ventricular ejection fraction dysfunction in a significant number of patients. It's not something I would want to give someone who's just come out of a thoracic surgical procedure in a week or two post-op, but I'd want real reassurance that they're significantly recovered. I mean, we don't have the trial data right now to say those patients don't need adjuvant chemo. Many of the patients in the FLORA trial were, 3B to 4, who had then had adjuvant chemo and entered the TKI bit of it after the chemo had been given. So, I mean, there's tantalizing suggestion that they may not need the chemo, but I don't think we're there yet. So I have to say, the adjuvant discussions, my honest opinion, when I see patients and I see palliative patients, it's usually very straightforward. Adjuvant patients are particularly complicated. I would say the adjuvant discussion I have with a patient, because you're talking about giving potentially life-threatening treatments to patients for a small survival benefit, a modest survival benefit. And we don't know whether TKI, in the case of Adora, actually translates to a survival benefit yet. So it is a very, very careful consultation, a very careful consenting process, sometimes involving several consultations. It's not at all uncommon for me to see an adjuvant lung cancer patient and have a conversation with them 2 or 3 times over 2 or 3 weeks to get their heads round whether they really want to have or not, because many of these patients are not young, fit. Many of them are actually quite elderly and have comorbidities, and actually trying to explain what the real benefit of adjuvant chemo is an art. It's not straightforward.
Understand. I think one final comment will go to Tom whilst we have him here. Interesting debate comment from Cora Ullman, but I entirely agree with Riaz. As surgeons, we should be concentrating on many surgical and perioperative innovations and perhaps leave oncology to those who do it best. And on this note, it's a great pleasure to get Tom back on, who's going to talk to us about evolving evidence for adjuvant targeted treatments after surgical resection. Tom, floor is yours.
Thank you very much. Can I just check that you can hear me?
Yes.
So I'm so sorry, everyone. I was subject to the vagaries of NHS IT. All of you who work in hospital, you'll be familiar with such joys. It couldn't cope with seeing and projecting. So I'm currently in my clinic. Here we go. On my phone. So where the NHS fails, the iPhone 12 will succeed. Come to my next slide, please. So there's my disclosures. Go my next slide. So some really interesting discussions that Riaz and Eric, you have had, and I'm very grateful to be asked to speak in this symposium. And what I thought I would talk about is go right back to the basics and say, actually, all the adjuvant therapies that you and Riaz have been discussing, what might they do? Well, there's a couple of possibilities. One of which is that they may actually eliminate residual disease. The other is that they may control that residual disease in the unlikely event of there being some, but actually it doesn't eliminate it. And of course, there's a possibility that your adjuvant therapy will have no effect at all. I'm not just talking about targeted therapies here, I'm talking about any adjuvant therapy. And if you therefore come to the eliminate residual disease, well, if you do that, you will cure the patient. If actually you control it but you don't eliminate it, you won't cure them, but you will delay recurrence. And then, of course, if your treatment has no effect at all, well, then you're actually going to be over-treating them with the best of intentions, but you will be over-treating them. So that's basically what we're giving adjuvant therapies for. And you may say, well, the only reason to give it is cure. And I have some sympathy in that view, and oncologists love that view. But I think we've also got to look at point number 2 and say, well, if you're delaying recurrence as a purist oncologist, that may not be as good as curing someone. Of course it's not. But if you're the patient, that's still a very valid and important outcome. Have the next slide. So the next thing I thought we would think about is how do we assess the effectiveness of adjuvant therapies? And on the left-hand side, you see a graph beloved of the oncologist, the Kaplan-Meier curve. And this is the LACE meta-analysis. And you can't go to any oncology conference about adjuvant therapies without someone getting this slide out. And it tells us really what the holy grail is. The holy grail is an increase in overall survival. And you can see that adjuvant chemotherapy did that. It increased the overall survival by 5%. And we all want to see that, albeit the in this, which is chemotherapy versus no chemotherapy, that benefit is quite small. But you don't always get overall survival benefits. It takes a long time for that data to wash its way through. And so we often use surrogate endpoints instead, which we believe and we hope will maybe mirror and reflect overall survival benefit. And we might look at disease-free relapse or relapse-free survival. And they're both very similar outcomes, aren't they? They're looking at when the cancer comes back. And of course, if we're ever going to look at effectiveness, we must also look at cost effectiveness as much as clinical effectiveness. And next slide. So the next thing is, what actually are these targeted therapies which you and Riaz have been talking about with such animation? Well, the first thing to say is they're concerning predominantly patients with adenocarcinoma. So on the left-hand pie chart, that is the big blue bit. And if we break down those adenocarcinoma patients, in a number of patients, we have driver mutations, by which I mean single mutations, which are the predominant cause of the cancer. And there's a whole bunch of them broken down in the rather unpleasant colours of the right-hand pie chart. And on the right-hand side, I've listed those genes. And those with a red triangle next to them are targets for which we have available and licensed treatments. And those in the slightly purpley triangles are ones which we have drugs coming through in the near future. So these are active drugs, and these are active drugs against established targets. Next slide. So to choose an example of this, we have EGFR mutated lung cancer. Now, this is the type of lung cancer which is for patients who you would not expect to have a lung cancer. More common in never smokers, more common in patients of Asian, Southeast Asian origin, more common in women than in men. And in the European population, it represents around 10 to 15% of patients with lung cancer. And the kind of golden rule I have, it's not an absolute number, but it's not far off accurate, is it represents about half of patients with adenocarcinoma of the lung who have never smoked. Now, the reason this is a really important mutation is that we can pick it up through next generation sequencing, which is now pretty much standard fare in the UK and Europe, and in fact most of the world. And we have a number of highly effective drugs called TKIs, tyrosine kinase inhibitors, against EGFR. And we routinely, Riaz and I routinely dish out these drugs for patients with metastatic lung cancer in our clinics. And I had a clinic this morning, and I can think of 4 patients this morning who are on TKIs. They have transformed the treatment of EGFR mutated lung cancer, and among the most active drugs we use in all of our lung cancer practices. So the natural question, of course, has been, if you have an EGFR mutation, do they have a role in adjuvant treatment after surgery? Next slide. So a few studies have looked at this over the years, because these are not particularly new drugs. They've evolved over time, and in fact, the first TKIs arrived on the scene just over 10 years ago. So people have looked at giving adjuvant TKIs instead of chemo, because I think it's fair to say that Riaz and I do not look forward to giving adjuvant chemotherapy to patients. It's a difficult treatment to give. They've had surgery recently, and they're quite toxic drugs, actually. So this is a study called the Adjuvant Study, sometimes called the CTONG 1104 study. And it took patients, as you can see on the left-hand side there in the box, stage 2 to 3A lung cancer, which had been completely resected. They've all got EGFR mutations, and they're in quite good nick, PS 0 to 1. And they received either chemotherapy in the bottom red box, a combination of two drugs, I think it's fair to be said, would be recognised as the most commonly used combination of drugs, or they got the EGFR inhibitor, gefitinib, one of the first generation drugs we used. So chemo or TKI. And the primary endpoint here was disease-free survival, with a slew of secondary endpoints at the bottom there that you can see. Next slide. So on the left-hand side, we've got the disease-free survival. And on the face of it, we say, well, that's fantastic. Line have done better than those having vinorelbine and platinum chemotherapy. In the red line, I can see that the disease-free survival is better. And in fact, if I look at the hazard ratio, it's 0.56, so almost a 45% reduction in the chances of disease being present. And so that's great. So we could slap ourselves on the back and we could give everyone gefitinib who's got an EGFR mutation. But actually, it's a bit more complicated than that, because you can see that separation of the curves that occurs quite early on. So look around 6 months on the horizontal axis, see the curves split there on the left-hand graph. But actually, they come back together again, don't they? In fact, by the time you get to 2 years out, it's all the same. So it really does smack of the fact that maybe you're delaying recurrence. You're not actually preventing recurrence. And indeed, that was shown when the overall survival data later came out, which is a right-hand graph. And you can see there's no statistically different separation of those survival curves. So delaying relapse is not actually preventing relapse. Next slide. And you can do lots of complicated post hoc analyses, which is usually a sign an oncologist is panicking because their study hasn't really proven what it wants to. And you can look at the various different subgroups and you can say, well, yeah, but if you still give them a TKI when they relapse, they still do the best. And that's true. But actually, my conclusion on this study is it didn't prevent recurrence. It delayed it. There wasn't an increase in overall survival. In other data I haven't shown you, it didn't prevent brain metastases. And so in my book, this comes into the delays recurrence, doesn't prevent recurrence, which is important, but I think is why this drug and this combination have never really taken off as an adjuvant treatment. Next slide. So if you're not going to give it instead of chemo, maybe you say, well, actually, chemo is still really key. We don't like giving it. Riaz and I don't enjoy giving our adjuvant chemos, but actually it's a really important thing to do. What about giving it in addition to chemo, if that is indeed needed? So this is a separate approach. This is a study called the Radiant Study. And you can see on the left-hand side, non-small cell lung cancer patients after surgery, and they either got chemo or didn't get chemo according to standard procedure of that treating unit. At that point, chemo had finished or it had been decided chemo wasn't needed. Then they got randomized to erlotinib, again, one of the earlier generation TKIs, or placebo. So this is a placebo versus TKI trial. And on the top right-hand side, you can again see disease-free survival Kaplan-Meier curve with, again, this separation of the curves, which we're finding maybe encouraging. And I think there's a probably more convincing separation of those curves. They stay apart a little bit longer, but they do come together again, albeit towards the later stages of the trial. They do come together again. And you can see, as I've highlighted in the graph at the bottom, if you look at recurrence patterns, what we found is that more patients on erlotinib actually recurred with brain metastases. So this was not providing a protection against brain metastases. So with those coming together of the curves, the lack of brain protection, this wasn't a trial that necessarily particularly changed practice. Next slide. And it adds to a couple of other studies of the same area. And what these tended to show, these three studies, if you look at this sixth column across, is they did show often an improvement in a relapse-free survival, but that didn't translate either to a overall survival benefit, or that was never really reported. And a lot of that is to do with how the studies were designed, the screening required beforehand. Did people do PET scans before? Did they do proper brain imaging before? And were they using the most up-to-date TKIs? And as time's gone on over time, we have found third-generation TKIs coming through in our metastatic practice. And that's really what's informed the most recent trials on adjuvant TKIs. Next slide. So the most recent study is called the Adora Study. I'm a little bit limited in what I can say about this due to licensing of drugs, but you will see that this is similar to what we've seen before. This is patients with early to some locally advanced lung cancer, common EGFR mutations, fully resected, and the patient either did or didn't get chemotherapy according to what the trials unit or the clinical team were going to do based on the standard decisions we make on adjuvant chemo. And they either got osimertinib or they got placebo as an adjuvant treatment for the time periods seen there. The primary endpoint was disease-free survival in the subgroup you can see. Of note, it's important to say that the Independent Data Monitoring Committee, the IDMC, closed this study early when the data became available. And obviously, it's something maybe we'd like to discuss in time would be the results of this study. So moving on to the next slide, again, I'm a little limited by what I can say due to the current licensing and compliance issue. I think it's fair to say a couple of things. Based on the trial data that trying to replace chemo with TKIs didn't improve overall survival, we should say first and foremost that adjuvant chemo remains the standard of care. If your patient with an EGFR mutation, has had surgery and based on their staging they need adjuvant chemotherapy, they should have that adjuvant chemotherapy. It looks like the arrival of next generation EGFR TKIs has changed the paradigm and improved outcomes. And I think what we now need to do is to work out which patients are best suited for these adjuvant TKIs. Now, you will also know from your other talks today that there's an increasing interest in neoadjuvant treatments, and particularly, for example, neoadjuvant chemotherapy and immunotherapy. And our focus is slightly swinging back towards whether there may be a role for neoadjuvant EGFR TKIs. This had to be looked at in previous studies. The basic tenet of this is that there is some improvement in progression-free survival, but the overall survival data has not become available yet. And with that, I'd like to finish. Thank you very much.
Tom, thank you very much for an excellent presentation. Well, thank God you got your sound and video back. That's all I can say. Can I ask a question which is on the minds of many surgeons and patients? Is that traditionally the adjuvant TKI studies never really showed an improvement in overall survival, but an improvement in recurrence or disease-free survival. And that's quite a consistent theme or picture for all the trials that you've mentioned so far. When I was working with some patient groups a week or two ago, a lot of them mentioned that the recurrence is a huge issue for them, and they would put it, not far off at par with death. And the reason was given by a patient, which resonated really strongly with me, was that freedom from recurrences allows patients to lead normal lives, allows them to send their kids to school and to get on with their day-to-day activities. And for them, it was a huge issue. Based on this, can I ask why is it that funding bodies and a lot of oncologists, because before, based on the studies that you previously mentioned, nobody really took much interest because of overall survival issues?
Yeah, Eric, I think you make a really, really good point here, and I've been definitely guilty of this. So, the oncologist sitting in the meeting, we want to see our overall survival data. We sit there pontificating about how very important that is because we want, of course, the best, and we want our patients to live longer. And I think that's driven by that desire to prolong survival. It's also driven by a desire that a lot of regulatory authorities, NICE, for example, attach a lot of significance to overall survival. But I think we do sometimes lose sight of it, because then when you're sitting in clinic with a patient and you would say, well, I've got this drug, for example, it doesn't improve overall survival, but it will delay when your cancer comes back. So I don't think we should really use it because it doesn't really make people live longer. They look at you like you're crazy. And they say, why wouldn't I have a drug which would delay the cancer coming back? So I think sometimes it shows a disconnect between what we as clinicians think is important and what our patients think is important. I think it is partly influenced by cost-effectiveness arguments of payers and regulatory bodies. I think in the end, overall survival is the most important. If you've got overall survival data for a treatment and it's something prolonged survival in total, that has to be key. But I think we have historically undervalued delaying a relapse and the quality of life that can buy people for that period.
And Tom, also, you mentioned the possibility of delaying relapse. In general, when we prescribe medication or drugs, we prescribe it within the confines of a clinical trial. So let's say if a clinical trial ends in 3 years, then that is tends to be the duration of prescription, whether it's due to cost or effectiveness. Do you think that in the as in the advanced setting, stopping a treatment which is highly effective at a certain point of time only begs to breed recurrence or progression when that treatment is stopped?
Yeah, and I think that's really the key question, and that's the question which we want to answer from Adora, and one needs to wait longer for that longer follow-up, and the study was closed early by the IDMC, and therefore I think we're never going to get the clearest of answers. I think there is a suggestion that, what you're doing is you're just pushing back recurrence, in which case should one continue the treatment indefinitely? Well, there's a very significant cost associated with that, and although EGFR TKIs are one of the easiest drugs that Riaz and I give, and osimertinib in particular, they still have side effects. They cause rash, they cause diarrhea, they cause paronychia, they can have other side effects, cardiac side effects. They're rare, but they happen. And so if you're going to commit someone to a treatment for many years, you have to weigh up those lower grade but longer term side effects with any benefit. I think what we really would love to know is, does giving an EGFR TKI, third generation EGFR TKI, does that improve overall survival? I personally think it will do. We will see that in the full, but at the moment the data we have is not quite yet to demonstrate that.
There's actually a question from the audience. Chiara Prodi asks, what did the Adora trial results show? Given that it's published in the New England Journal, I think there's a lot of it in public information.
Yeah, that's correct. It's all to do with what the drug's licensed and so on. But I think we're able to share. So it showed a very, very impressive improvement in disease-free survival with a hazard ratio of, I think it was 0.3 from the top of my head. So huge improvement in disease-free survival, really unprecedented in an adjuvant TKI study. There was no difference in overall survival, statistically significant difference in overall survival, but that represents the immaturity of the data. So I think it's really very impressive reduction in disease-free survival, and we wait to see what the OS shown. And that's created a lot of debate among oncologists who have nothing best to do with their time as to whether a very powerful DFS, disease-free survival result is sufficient to change practicing habits, and does that mean we will definitely see overall survival data, or whether the more purists would say we just have to wait for that OS data.
And one final question, a very surgical question from Mohammed Diab. He says, do you, like surgeons, we use a consent form and consent patients for surgery. Do you actually consent patients formally when you prescribe TKIs? And if so, what percentage, risks do you quote?
Yeah, I think that's a fantastic question. So we do, and we do it quite formally. We actually, in the UK, we have pre-populated consent forms that are written by Cancer Research UK with the relevant side effects. We tend to group them as very common, and rare, based on the frequency. And you kind of go through everything. And I think you focus more on the side effects of TKI, but we do mention the rarer side effects such as pneumonitis and cardiac toxicity, albeit them being rarer. But having proper consent is completely key.
Great, thank you very much. I think we'll close session here and we'll start the final talk. So next slide, please. So you know us, I'm Eric, and then you know Tom. Next slide. And here are our disclosures. Next slide. And next slide, please. So let's present a case about how we actually work together in real life. This is an actual case that we shared. An 83-year-old lady who presented in 2018, who was diagnosed with a left lung mass for over 6 years, which has been followed up on CT, which brings me to another point about CT screening, but maybe at another presentation. She had smoked 10 cigarettes per day, age 18 to 28, and that's only a very small amount, 5-pack years, I would say. Without any history of cough or hemoptysis, no shortness of breath, exercise tolerance was unlimited, had a performance status of 0. She had a number of comorbidities. She had chronic hypertension with cardiomegaly, which is quite impressive. I'll show you in the CT, and a history of atrial tachycardias. Next slide, please. So this is her CT chest, and the first thing you notice is that how huge the heart is and how it's completely filling up the chest. From the right side of the lung, you would see that this is not a diaphragmatic view. This is actually a section from the mid-thorax and how the heart was occupied in the mid-thorax. She presented with 2 lesions, a large lower lobe lesion and a smaller middle lobe lesion. Next slide, please. And on PET-CT, she was noted to have a very high PET avidity for the lower lobe large lesion and no PET avidity for the lingular lesion. And therefore, a decision was undertaken to bring her to surgery based on the resection of the left lower lobe large lesion. Next slide, please. This lady underwent a bronchoscopy. We started out as a single port left VATS, and all we could see was heart, and more heart. I couldn't access anywhere into the lung and had to resign myself to convert to a thoracotomy. After that, it was relatively straightforward. We did a systematic nodal dissection, a lower lobectomy, and a wedge resection of the upper lobe nodule. Lymph node station 5, 6, 7, 9, 10, and 11 were submitted for histology, which was then reported back as PT4 because both nodules turned out to be malignant, N2A2, PL2, R0 adenocarcinoma. And next slide, please. And following on from that, it is a routine practice for me to then refer the patient back to our friendly oncologist, Dr. Tom Newsom-Davis.
Thanks, Eric. So I met this lovely lady about a month after her surgery, and she'd recovered very well from it, actually. She wasn't a young lady, as you can see, but she'd done very well. And she came in to clinic, and she was probably a fairly solid performance status 1. And she knew then already that the original histology had shown an adenocarcinoma. We do routine molecular analysis, such things as PD-L1, which, as you know, is one of the markers of immunotherapy. But given her the N2 disease and the T4, she actually also underwent next generation sequencing to look at what molecular analyses she may have. And you won't be surprised to hear that she had an EGFR mutation. This lady was a never smoker or very minimal smoking history. We did a whole bunch of other mutation testings which were negative. So here's a lady a month after surgery with N2A2 disease, T4 tumor, who's EGFR mutation positive. So, next slide, please. Question is, this was back in 2018, what were her options? So I could have given her adjuvant chemotherapy. We looked at the LACE meta-analysis at the beginning of my talk, and we know that gives around a 5%. That's a little bit more for her overall survival benefit based on her stage of disease. We could have given her adjuvant radiotherapy back in 2018 based on the mediastinal lymph node involvement, although that's always been a little bit contentious. And in fact, since 2018, data has come out to suggest that's probably less effective and is less routinely done now. And I could have given her an adjuvant TKI based on some of the early data I showed you, the Radiant study, for example. But actually, it's all about what the patient wants. And we could just click to the next bit. What we found actually is that Elena didn't want any of this. And I actually supported her in that completely. She didn't want adjuvant chemotherapy, and I wasn't keen on it either. She was a performance status 1. She was probably actually really a performance status 2. She was in her 80s. The evidence base of adjuvant chemotherapy in people over the age of 75 is actually not great, based on the fact they're excluded from trials. She wasn't keen on chemotherapy, and I wasn't very keen either. Didn't want adjuvant radiotherapy either, and we went through the limited data that we had for adjuvant TKIs. She didn't want that either. So Elena said very nicely, thank you, but no thank you. I'll pick up my surveillance and we'll see how we go. Next slide. Fortunately, surveillance didn't last very long because within a few months she had relapsed, and you can see her PET scan here showing nodal recurrence in the 3 sections there, as well as an effusion. I'm using it on a phone, so it's extremely small to see, but I'm sure there's a fusion hanging around there somewhere as well. So unfortunately, she recurred. She actually remained extremely well. She'd improved since our first appointment as she'd recovered from her surgery. And next slide. So there she was, fairly stable. I reviewed her history. She had a history of tachyarrhythmias under a cardiologist. She had a normal ECG. She actually had quite well preserved LV function. She had a normal QTC. And this gets back to the excellent question one of your colleagues asked Eric about consenting patients, because I consented her to start a third generation EGFR TKI, and they can be rarely associated with cardiac side effects. I wanted to make sure that from a cardiac point of view things were stable, and they were. So she started her TKI. This was probably around, if a memory serves, 6 to 9 months after her surgery, now that we knew she'd relapsed. So next slide. She had a beautiful response. Within 3 months, complete metabolic response. All the FDG avid nodes had resolved, slight reduction in the pleural effusion. And next slide. But no drug is without side effects. And so after about 4 to 5 months on treatment, she had a grade 2 diarrhea, grade 2 rash, and grade 1 rash and grade 2 fatigue. Just to remind you, we grade our side effects in oncology 1 to 5, 5 being fatal and 1 being mildest. And so grade 1 to 2, they're all mild, but they're not very nice things to have, particularly if you're in your mid-80s, and diarrhea can be really quite an unpleasant symptom. So I actually dose reduced her after a few months on treatment, and her diarrhea resolved to grade 1, as did her fatigue. Her rash completely went. She had an episode of atrial fibrillation, but that was felt to be probably unrelated to the drug by her cardiologists. So we do often fiddle around with treatments, and she stayed on that treatment with these low-grade side effects. Next slide. So I saw her about 3 weeks ago, and she's still on her treatment. She's been on it for over 2 years. She has an ongoing complete radiological response. She has no increase in side effects. And actually, if you're in your mid-80s, it is problematic having diarrhea. So it does actually affect her quality of life a bit, but she is managing with that. She is looking forward to a lockdown finishing and going back to the theatre. She's a very active lady for her age. So here's an example of someone we didn't use adjuvant TKIs for, because at the time they were unlicensed, and at the time they were not available in that setting. And I guess the question would be, if we had given her adjuvant treatment, could we have prevented her recurrence? Could we have delayed her recurrence? And would there have been benefit for her either way? Or actually, would it be better for us just to wait for her to recur and to treat at that point? And that's the end of my part of this presentation.
Thank you very much, Tom. Next slide, please. Just a general question from the audience. Do you think that we should be doing reflex testing in all our patients now after lung cancer surgery? Maybe we can bring Riaz into this discussion. Riaz, what do you think? Reflex testing?
Definitely, yes. We've been doing reflex testing in Kent for years now. I mean, it's just a no-brainer, because most patients end up having advanced disease, if not at the beginning, later on. And, you know, knowledge is power. So the more information you have about the cancer, about the tumor, the more you're able to give appropriate advice to that patient. So I'm all for it.
I absolutely agree with Riaz. In the old days, we used to get kicked back doing these things. The cost of doing EGFR testing, usually lumped together in next generation sequencing, has come down. It's peanuts, frankly, compared to the costs of, for example, the surgery and the admission and all the tests. So I think we should be doing this. And if it was your relative, you'd want them to be tested. And
with regards to the cost, how will this be provided?
Genomic hubs. It's all standard now. I don't think there's a cost really you need to worry about in your NHS practice.
Yeah, you won't get a bill. All centrally funded. 10 years ago, Riaz and I would argue with payers, and they would get stroppy letters saying you've done an EGFR test on such and such patients. Now no one even looks, and I think we should be doing it. I would add we should be doing it for our non-squamous patients. There isn't really a role, apart from in unusual cases, young non-smoking patients, there isn't really a role to do molecular analysis in patients with squamous cell cancers at the moment, or small cell.
Yeah, Tom, this is a good question from Adrian Marchbank, the surgeon. He's asking, when tumors recur, will the molecular profile be the same as the original primary? And with regards to this case, for example, she was EGFR positive for the resected tumor. Therefore, can we assume that she will be positive for the progression of disease? And also in this setting, presume the licensing is different. In this setting, she was allowed because she was presented with a stage 4 setting.
Yeah, so I think that's a really, really good question. So she relapsed pretty quickly. And so on that basis, I think we were fairly confident that her tumour was unchanged. But you're absolutely right that cancers change over time and they change in location. And so I can think of another gentleman whose disease relapsed after surgery 8.5 years later. He was extremely unlucky. He was known to have an EGFR mutation at the beginning, and I repeated the molecular analysis on a new biopsy. So I think if it's longer away, I would certainly be repeating it. And in fact, what we usually do in EGFR mutated lung cancers is when a line of therapy is no longer effective, we often rebiopsy again to look for resistance mechanisms. I think that's a really good question. You're right. The reason I was able to give the TKI for this particular lady is she has metastatic disease. She'd recurred in a non-surgically resectable way the second time round, and that changed the licensing indication of the drug.
Excellent. Thank you so much. Next slide, please. I think now, next slide after this, please. All that leads me to conclude is to thank both our speakers, Dr. Riaz Shah and Dr. Tom Newsom-Davis, both fantastic speakers today, and brought really a new level of engagement to this really important topic. I also want to thank AstraZeneca for allowing us to have this forum for which we can discuss these important issues in how we can improve survival of our patients going forward, and also bringing us closer together with surgeons and oncologists working together. Finally, to thank the FCTS for allowing us to overrun slightly for this session. Thank you very much, everyone, and I look forward to the next session when we meet.
Bye, everyone.
Bye.